And then, can everybody see my screen?
Yes.
Fabulous. Okay. So in terms of your maternal history today, this lady is a Gravida 2 Para 1. She had a previous instrumental delivery in 2013, which was uncomplicated. She's 26 years old with a BMI of 38, O positive, virology and scat is NAD, and bloods with booking were normal and her admission bloods were normal as well. Apologies that they're not on there. She was a late booker at 27 weeks and there was some safeguarding history with this pregnancy. She had multiple DNAs, so had very limited antenatal care. Declined her GTT on 3 separate occasions, and in terms of engaging with the services, wasn't particularly compliant with it. And then her last ultrasound was at 40+1, mild polyhydramnios. I think the deepest pool was 8.6, and cephalic presentation, normal fetal growth and Dopplers. So she came in to triage on the 23rd of the month with query Schrum on the 22nd at 10 p.m. So this is now sort of 3 hours later. She's contracting 1 to 2 in 10, feeling tightening at the moment, but nothing sort of moderately or hard on palpation. At 01:30, ROM plus was done and was positive. VE was 1 centimetre dilated, presenting part at -3 and a Bishop score of 4. There's a slight paper jam on the CTG, and Dawes ribbon, which was really good, was not started. So this is your admission. This is your triage CTG to start off with. Okay. So there was a decision made to admit her to antenatal ward given her history. This is the admission to antenatal ward CTG. Dawes ribbon criteria was started. I have escalated that to the midwife. But yeah, are we happy with this?
Yes.
Yeah. Anybody want to keep it on for a little bit longer? Oh. No, I'll move on then. Perfect. So, sorry, apologies. CTGs that were taken overnight. So the plan was for 4 hourly. CTGs that were taken overnight were completely normal. And then on the 23rd as well. So we're still within that 24 hours. This is the morning CTG on antenatal ward. Are we happy with this one?
Yes.
Yeah.
Yeah, I think
sorry, Maya.
No, just said happy, thank you.
Perfect. So the next trace is later on in the afternoon. So we're now moving on to 10 past 7 in the evening, and this is the CTG that was on our antenatal ward. Criteria again, Dawes ribbon criteria was used again, and that has been escalated. And she's contracting 1 in 10, and they are mild to moderate on palpation.
How long are we now since the Schrom?
So she Schrom at 10 p.m. the following evening. So it's now 7 p.m. The following day.
So yeah, so 24 hours now.
Not quite, 22 hours ish.
Okay. Yeah.
Yeah, and then this is the second segment of your trace here. So she was transferred over to labour ward due to the decelerations that you can see, for closer monitoring and to make a plan. And then at 8:30, she handed over to the labour ward midwife. Okay. So at 20:40 on ward round, she had a doctor's review. 20:46, she was moved into the left lateral position due to the deceleration that you can see there. And clear liquor remains draining. Her observations are at the top there. Blood pressure of 131/86, pulse of 69, SATs of 97%, temperature of 36.9, and respiration rate of 17. Are we happy with this trace?
Petro raised her hands.
Yeah.
Sorry, I can't see anyone other than.
Oh, sorry, Cara, just a quick question. Was she examined on a ward round, like vaginal examination?
No, that comes a bit later.
Okay, thank you.
Was there somebody else that had a hand up? Sorry.
Yeah, sorry. My name is Dagmar. I'm joining your kind of CTG. I at the moment struggle to make out where the base rate is in this particular CTG segment. Does she report that the baby is moving a lot, or is somebody feeling if the baby is moving?
No documented report of fetal movements, but there's been no concerns with any movements throughout the day, so it could have been that this was the case. But yeah, totally agree with you, Dagmar. So in terms of moving forwards, it's really, if we can't determine the baseline and we don't know, it kind of looks like at one point it's sat around 160, 170, and then in other places it looks like it's sat at 120. So yeah, difficult to determine where our baseline is. And if we look at the previous CTGs just quickly, we were at sort of 140 previously, so during the morning, and then this is in sort of 12 hours later. It's a little bit more difficult to determine.
And just to get the story right, sorry, because I missed the first bit. She's a term woman who ruptured her membranes, has clear liquor, but you admitted her because of?
Safeguarding concerns was the main reason for admission.
That's fine. So I missed that part. So is that she essentially doesn't kind of go out and doesn't come back after prolonged rupture of membrane? Okay.
Yeah.
Okay, but she had previously delivered normally. Did I get that right? Sorry about that.
No, it's okay. Previous instrumental delivery in 2013.
Oh, good. That's fine. Cool. Thank you.
Perfect. So the midwife is expressing some concerns to the obstetric registrar due to the fact that she's finding it difficult to interpret the trace. This is following the doctor's review, but the registrar at this point is happy with the CTG and says to continue and keep close observation. So we can see this on the next slide here. Yeah, so that 2120. So at the end of the last segment, the midwife asked the registrar to review and was happy. During this period of time in between, so between this sort of 2040 and 2120 time frame, there's been multiple moving from left lateral to more semi-recumbent to throne position to left lateral to semi-recumbent back to throne position. And so the midwife is finding at this point that the maternal position is helping to recover any of those decelerations that we're having. Does anybody want to make a comment on these at all?
They seem to be more barrel. They are coinciding with the contractions, so therefore I wouldn't necessarily be worried about that if I knew where the base rate actually is, because not being able to kind of say where the base rate is a bad sign until or unless you know that the baby is moving. So therefore, without that information, I find the non being able to identify the base rate worrying. Yeah.
Yeah. Absolutely, and yeah, definitely with those baroreceptor decelerations, and also the fact that moving positions is another sign that these are baroreceptors, because actually changing the position and changing possibly the pressure on that cord may help the baby recover from those decels. So we'll move on. This is the next sort of 40 minutes of the trace here. A cannula was inserted at 2200, I think, with the idea to give fluids. And then at 2205, she went out to the toilet. So are we happy with this trace now?
Yes, it is matching again the previous 140 baseline. I think, yes, definitely.
Yeah. Okay, we'll move on then. So we're now at 2210, so we're definitely now prom. At 22:15, Hartman's was started, and then all that's sort of documented is that at 22:39, clear liquor is still draining, so she's having pads changed regularly. And the most recent set of observations there: blood pressure 135/72, pulse of 63, respiration rate of 17, SATs of 98%, and temperature of 36.5. Happy to continue?
Yes.
Yeah, wonderful. Okay, so at 23:10, the lady is now feeling some slight pressure down below. Is feeling is sort of trying to involuntary push. And the midwife sort of documented on the tracer that the TOCO was adjusted. I don't think it was picking up the contractions particularly well, although they look very clear on here. Just something I say on every single one of these reviews. Please, our lovely midwives and obstetricians, when we're writing on the CTGs, can we please not write through the baseline? There is a digitalized version of this that you can document electronically, or just not on the baseline, because it can alter the way that we can see what we can try and assess what we're looking at here. Okay, but I'll be happy with this.
So, yeah, Cara, Dagmar put on the chat what is the IV fluid used for, and I think we talked about the IV fluid multiple times in this CTG meetings, and that it doesn't improve or do anything to the CTG except in cases where ladies have been coming with dehydration and so on. So yes, thank you, Dagmar. Yeah, IV fluid is yeah, it is something that is people still like to do because it makes them feel happier. And yeah, Dagmar has raised her hand.
Yeah, absolutely. It happens on a quite a regular basis. There wasn't any indication for fluids documented. Sorry, there's if you can hear a lot of background noise, somebody's having an argument in my car park at the moment. But yeah, Dagmar, did you want to add anything to that? If and Naguib said you've got your hand up.
No, my sincere apologies. This is a new version of the kind of MS Teams for me, so therefore it doesn't have the same functions. And no, apologies, did not mean it.
That's okay, don't worry. Did somebody say something? No, okay. Okay, so we'll move on. So due to the fact that this client was feeling some pressure, the midwife examined her and found her to be 3 centimeters dilated. And that was at just the middle of this section that you can see here. She was requesting to have a shower to freshen up. The midwife in charge and the registrar were happy with the plan to take her off the trace for a short period of time. So that's exactly what happened. Does anybody agree or disagree with that at all?
No, we agree, but I just want to know more about the 3 centimeter. Is the head lower? Is did they feel any for water? Did they, like anything else?
No four waters, presenting part still -2 to -3, and cervix is partially effaced and posterior.
Right, which is slightly, like doesn't fit clinically, but yeah, from contracting and feeling pressure for the head to be -3. But yeah, let's continue.
Yeah. I don't know whether that was she was feeling slight pressure because she'd gone from maybe 1 to 3 and felt the baby had moved down slightly lower, but this is the report from the examination that this lady felt. Okay, so it turns out that she was off the CTG for about 30 minutes, and this is your trace when she comes back onto it. Are we happy?
Yeah.
Yeah. Okay, going to continue. So your second segment, so this is the next 45 minutes here. Some nice accelerations there. Baseline's kind of reduced a little bit as well.
Everything is fine. Yeah, everything. Yeah, it is just the
Perfect.
TOCO. The TOCO is all over the place, but fine.
Yeah, at this point, so the midwives clearly documented that she was contracting sort of 2 to 3 in 10, and they were moderate on palpation. Sorry, I haven't added that to the slide. Okay, so we'll move on. So it's now 2 o'clock in the morning. So she's now 28 hours prom. Observations are stable, as you can see. Blood pressure 122/87, pulse of 70, resps of 18, sats of 96, and temperature of 36.4. A little bit of loss of contact that was apparently audible at baseline throughout the CTG at around 02:33. But otherwise, we're still happy to continue. Normal variability, stable baseline.
Yeah.
Yeah.
Yeah, wonderful. So she went out to the toilet at around 02:55. The midwife was requesting for a registrar review at this point, but was unable to attend due to ward activity. It's just worth noting our human factors in this case. The high activity on labour ward, there was a solo registrar working, so unable to attend and come and review. But at this point, the client was requesting an epidural. It's now been sort of just under 3 hours, 3.5 hours since her last examination. And due to the fact that there was significant changes on the CTG trace from previous, it was recommended an examination prior to epidural insertion. So what we're thinking now?
Somebody else than me then. So
Hi. So the classification of this CTG would be suspicious, according to FIGA guidelines. So conservative management that had worked previously might not work in this case, I don't think.
And why would you think that, Petronella?
Sorry, I'm driving and trying to concentrate. Because the variability is reduced now. So there's two different things that are happening. She's having decelerations and the variability is slightly reduced.
Yeah.
So before, we know that there were baroreceptor deceleration, so we could change that with changing position and things. But in this case, I don't think that would change the CTG.
Perfect. Yeah, absolutely agree.
I slightly differ. You know, like at the moment we are getting more of like, if we want to say what we are going to have really, or it is gradually evolving. So this is if we are talking physiology, but at the same time the baseline is still 140, so it has not. And to me the variability, I think variability remains fine. It is not very altered really. So I'm still I wouldn't jump to deliver with this.
Would you classify as suspicious though, Nagib?
Yeah, I would classify suspicious. Yeah.
Yeah. So are we doing a sit and wait approach to this, or is there anything additional that you would recommend that we do to help improve the trace in any way?
Yeah, I would sit and wait. I don't think, although the talk again is giving me the impression that she's contracting, I don't know, maybe 5 to 6 in 10. I'm not sure. It needs a little bit more of information. But as far as the information given to me at the moment is sit and wait, and yeah.
Yeah. Okay, so this is your next block here. The epidural was set up at 0350, and then epidural testose was given at 0403. Blood pressure 131/87 and pulse of 67 is all that's recorded alongside the sats of 100%. I'd just like to point out that no further observations were taken from here until postnatal. Does anybody want to remind us of the guideline when we've got a woman on woman having an epidural in terms of frequency of observations?
half an hour blood pressure and hourly pulse.
Yeah, absolutely. So just the one blood pressure was recorded throughout the epidural sighting. I don't know whether more were done and not recorded, but it's just another sort of key point here is to really make sure that we're documenting all the observations that we're doing. Specifically with the epidural sighting, we want to be making sure we're doing that blood pressure every 5 minutes after the test dose has been given, and then moving towards the every half an hour following that. But yeah, just as another sort of key message here. But the good thing about this is we know that we were picking up fetal heart rate during the epidural being sighted, which is really great for the midwife that was caring for this lady, because for those of you that have done these reviews before, we do have it quite often where we just pick up maternal pulse for quite a long period of time during when the anaesthetist is sighting the epidural. Okay, so we'll move on to the next segment now. So at 04:30, this lady was moved into the right lateral position. The registrar was now out of theatre, so was able to come and review. So this is the 04:35, so after my second blue bar there. Registrar now present. The cervix remains 3 centimetres. Presenting part, I think, is -1 now, but not fully effaced at all. And the registrar recommends some Synto in view of slow progress. Can I ask, would anybody, just if we cut off the second half of the trace, would anybody agree or disagree to start Synto on this baby so far?
No, I wouldn't want to.
Why?
The fact that babies decelling, although, you know, there is good variability, but it doesn't seem that there's a stable baby at the moment for me to want to start Synto. She is contracting. I
Yeah.
don't actually yeah, I just wouldn't want to start Synto yet.
So the contractions that the midwives reported are 3 and 10. She has documented that they were strong on palpation. But yeah, does anybody agree or disagree?
I also wouldn't start Cento at all on this trace. You know, like as we mentioned in multiple of our sessions, Cento on a CTG that we are, all of us really set suspicious and physiologically gradually evolving is the most important and the most common iatrogenic cause of hypoxia. We are creating the hypoxia, to be honest with you. So we are exacerbating whatever is present. So if we are adopting the conservative, yes, but if we are like even giving more harm, no, the Cento is forbidden, I would say here. I know
Yeah.
the old school, or what I heard when I was a reg, was start Cento, either it deteriorates and we section, or either she delivers. I don't think this has any role, because medico-legally you are bound to make the baby hypoxic, and then you might not be able to resolve the problem. So I wouldn't agree.
Perfect. Okay, so that was at 04:35. Anything else sort of not really reoccurring? What would you expect when a VE was performed? Maybe some sort of fetal scalp stimulation. We may expect to sort of see something on the trace that reassures us that baby's reacting to it.
By this, if you say the first half of the CT, you are still talking first half or the whole segment?
Still first half. So that, I think the documented note on here was actually later than it actually happened. So the examination was performed at 3 centimeters was at 04:35, but it's sort of written on the tray slightly later on.
Okay, so if we are talking the first half of the CTG, I think I wouldn't do anything yet. It is 3 centimeter. We have already examined her an hour ago, so nothing will help here. But by the end of the segment, I can say something else, but not now yet.
Okay, lovely. So the registrar has obviously recommended the Synto. The midwife that is caring for this lady is expressing her concerns, and the midwife in charge is also of the same opinion that actually in this case that Synto may not be recommended for this baby. So there was a delay in obviously starting this due to sort of clinical disagreement. And then, as you can see, as the trace progresses on further, we are getting some more decelerations with our contractions now, and she's now still contracting sort of 3 to 4 in 10. They are strong on palpation. And then at 04:54 or 04:55, she was moved to left lateral again. So this midwife is still trying to try and change position to see if the baseline comes back and recovers well from those decels. And then at 05:04, terbutaline was given.
Yeah, that's what I wanted to say. Terbutaline at the end, yes. But what I want also to say is that apart from the CTG, we need to remember that a multip should be contracting, yes, 4 in 10. We wouldn't increase more on that. So again, if she's contracting 3 to 4 in 10, according to the midwife, why should we put Synto on? Yeah, just a comment.
No, absolutely. Mr. Naguib, you'd agree to give terbutaline in this case?
Yeah, I would. Yeah.
Okay. Lovely. So it's now 05:10. The second bag of Hartmann's has been started at 05:20. Obviously, we need the Hartmann's running because she's on the epidural now, and that was more of a sort of justification for starting the second bag of Hartmann's. And the trace continues.
Catheter is in.
Yeah, catheter's in.
Thank you.
Sorry, I haven't documented that. Yeah, catheter is in. At 05:45, the midwife is again asking the registrar for a review, and is recommending, alongside the midwife in charge, that pre-meds should be given, as the likelihood is that this lady may be going to theatre based off of the trace. Yeah, so we can see the terbutaline's work. She's now contracting 2 in 10. We're still concerned with the CTG though.
Concerned, but not to deliver yet, I would say, or I wouldn't deliver yet.
So we're just a sit and wait approach.
Yeah.
Happy to wait, yeah.
Yeah. Okay.
Sorry, just from a student perspective, why would we wait?
So at the moment, sorry, Naguib, are you okay for me to answer?
No, please. Oh yes, my friend. Yes.
So well, at the moment, the question that I'm having is actually, so I have a multip with prolonged rupture of membrane who seems to be contracting adequately, but there's no progress. So I'm wondering if this baby's in malposition, or if there's a cephalopelvic disproportion, if there's anything that holds this baby off. So if I even give terbutaline, because the placenta doesn't seem to be the best working, so there are chemo components to this, but this baby is not lowering the pH with this. The stable base rate normal variability means it's not getting hypoxic, but neither do I feel particularly inclined on somewhere that I give terbutaline to do anything more about the contractions. But then I just have time. Then you just have to kind of see, is this baby descending? Do I, with the next examination, have essentially a effacement? Do I have any signs of caput? Is there essentially a cephalopelvic disproportion? Because she didn't engage well with the services. She herself has a high BMI. There might have been poly. This might be a large baby. If I have evidence of cephalopelvic disproportion, I would not wait. That's the time then to bail out. If you have the impression that there is a long latent phase, maybe because of an OP baby, then you can wait. But this baby per se is not unwell. It has a stable base weight and normal variability. And multiples, the hope is, you wait, and then they're going to labor there fast. So therefore, if you reach that point, fine. But if the baby essentially kind of says the placenta doesn't hold for this, then you would be bailing out. But you don't have to do that based upon these decelerations at the moment. That would be my thinking.
Thank you.
Okay, so we're going to continue. So at 0600, the registrar is very busy and is currently in theatre. At 0614, the emergency buzzer is pulled. At 0615, she's moved to left lateral. Although we've got limited contact, again, just as a sort of quick question, would anybody would have recommended an FSC back here when we had some loss of contact?
I don't think I would at the time.
No. Yeah.
No.
I think we have a good trace, to be honest. I don't see any loss of contact really. It's except maybe at the end of the segment, but yeah, it is reflecting the reality really. Yeah.
Yeah. So I'm just thinking in terms of that last sort of 10 minutes, there is sort of limited contact. It does improve though, which is great. But yeah, maybe have an FSC possibly in the room, maybe on standby, just in case it's necessary and we do lose contact. Because like Dagmar said, and as on the first slide, this lady does have a BMI of a raised BMI of 38. So it may be that in terms of baby moving position, we may lose some contact quite significantly.
Shivs has her hands up, I think.
Okay.
I was just wondering, like, just where it continued to decelerate, would we not have, I mean, I didn't count the time, would we have not considered a second tebutalin? But to be fair, I didn't see this lady's history. I joined a little bit late, sorry. But
so she's a multip. She had a instrumental in 2013. BMI of 38, mild polyhydramnios of 8.3 centimeters, non-engaging with her antenatal care, significant history of safeguarding.
Mm-hmm.
I don't know if that.
Yeah, no, I just wondered if we wouldn't have considered a second lot of tebutalin. I don't know what everyone else thinks.
When Shiv, in any part?
So, Cara, just go back a little bit. And just take
so tebutalin was given.
Yeah.
Tebutalin was given at 0504.
Right. Okay. And then.
This is the next.
This is 6:10, 6:15. I mean, it is a bit difficult because I can't really see what the contractions are doing at the bottom there. It's not really It's not.
So this point, the contractions are reported sort of 2 to 3 in 10 and still strong on palpation.
Yeah, for me, Shivs, I wouldn't. If I go to the previous segment, the baby is above the baseline 90% of the time, I think, more or randomly.
Yeah.
So if I'm thinking baby is coping, there is no need to slow down because, as Dagmar said, is one of two things: either she will continue because of the steam of being a multip, or she will. So if I am not too worried, I wouldn't slow it down.
Right. Okay.
Yeah. So concerning the FSC, like I want to say that when I was in George's, for example, FSC is done for everybody because of Stan. And FSC is fantastic. But at the same time, if I have a good trace, I wouldn't be applying it because as doing the postnatal debrief, I see many ladies coming who are really traumatized, not because of the FSC itself, is because we don't explain much what is FSC, what is it going to do, and in some occasions, some babies had the FSE on like very important parts of their body, like on their eyelid and and they have left marks on the scalp. Yes, I am an advocate for FSE. If you have a loss of contact, yes, if you are even in 1% doubt, put the FSE. But if you have good tracing and you are sure it is the fetal heart, not maternal, I would continue with that.
But
Of course,
sorry, carry on, Naguib. Sorry.
of course, in twins, the situation is quite different because I would, I in 100% of the twins, I would love the FSE because I have two babies at this situation. So yeah, please shift, yeah.
So no, I was just thinking in terms of the tibutalum, we're saying not here, but even as you get further along, just before when we decide to do a cat one, obviously
Yes.
we don't have the best contact. Could we not have considered that, or are we then thinking because we're potentially going to do a section? It's just because obviously we've now got, we don't know what, like the baby looks bradycardic at this point.
No, if terbutaline again is one of the best drugs. If you are feeling you are doing a section, go give terbutaline, move to theater. By the time they top up the epidural, they put the spinal, whatever, the terbutaline effect is less, and the benefit of it is much higher than any harm. And whoever is doing the cesarean can stop the bleeding by centometrin, by misoprostol, by hemabate, by all things. And it is a short half-life. It is not like she will bleed forever. No. So it's not a contraindication if you are going for section.
Can I just ask Cara, why did we not start Cinto earlier when there's an episode of a normal CTG for this lady? I think if you consider where we thought labor had started, where she was transferred from the antenatal ward to labor ward, clearly the contractions she's having are not effective. They're not labor contractions because they're not doing any effacement to the cervix or any descent of the fetal heart, the fetal head. So why did we start Cinto considering she was prom somewhere in the middle there?
Let me go back for you. So first examination, so she had an examination on Hope Ward. An examination was done here at midnight, so she was still 3 centimeters, which is what she was when she was transferred over from from antenatal ward. So then she ended up in the shower, normal trace here. I don't know whether because it was more of a sit and wait approach, that's the reason for not starting Cinto, but because she was contracting regularly at this point, I believe that the hope was that she would progress. And then by the time it came round to her next VE, at this point she was requesting an epidural, and by that time the trace had started to become suspicious, so you wouldn't have wanted to start Cinto on this trace.
Okay, thank you. Got it.
Where are we? So okay, so this is where we are now. This is where we're at now. Emergency bell has been pulled. Fetal heart rate is down to 86 beats per minute with a maternal pulse of 70. This is very well documented as well that this has clearly been done, because we've had cases in the past where maternal pulses has not necessarily been palpated during the deceleration. So we've not got that clarity that that is fetal heart rate as opposed to maternal pulse. So that's just a really good point to go forwards with. Always make sure that you do record this if you're ever in a bradycardia situation. 6:15, she's moved to left lateral. 6:17, she remains 3 centimeters, done by the obstetric registrar. So at 06:20, decision was made for a category 1 cesarean section. And then just to confirm that that was indeed fetal heart rate, one of the additional midwives applied the FSC and confirmed that the fetal heart rate was 70 beats per minute. And that's at 06:23, so at the end of this trace now. So the deceleration starts at sort of 06:14, and at 06:23, that's when the FSC is applied. Going forwards, we know that we've determined that maternal pulse and fetal heart rate are different. We kind of losing the contact, so it's more difficult to monitor it through the abdominally. Would anybody have held off on that? Does anybody have anything to comment on in terms of the FSC application at this point?
No, it's fine. It's yeah, it's
Perfect. And it did come very much in handy because when we got into theatre, although a very, very limited amount of trace at this 3 minutes here, the FSC was applied prior to cleaning the abdomen, and we can clearly see that that is fetal heart rate here. So really quick and good decision before transferring to theatre. At 06:30, that's when we entered theatre. At 06:38, general anaesthetic was undertaken. And then at 06:40, knife to skin, and then at 06:43, knife to uterus and delivery. And there was thick meconium present at delivery as well. So bradycardia 9 minutes prior to transfer. Actually, more so than that. Apologies. I think it by the time it had been down 06:14 to now, this trace here is 06:30. So we're about 20 minutes of a bradycardia at this point.
I would, yeah, I would, while the prolonged deceleration was going into the room, while I do the left lateral and this and that, I would have given terbutaline again here and moved to theater, yes, put the CTG on, and if it has recovered, I would have allowed time for top up of the epidural rather than GA. So this is the, yes, cat 1, but with a top up of epidural or a quick spinal by the anesthetist. So I would try to avoid GA if possible. Of course, if it's not possible, it's fine. But we are all aware of a recent failed intubation in a GA, and luckily we didn't lose the lady, but we were about. So if we can give terbutaline, think about the whole global scenario while we are moving to theater. By the time we reach theater, terbutaline would have worked. CTG goes up to 140 again. Yes, she's still 3 centimeter. Yes, she is, the baby's heart rate has done this. I would still proceed with the cesarean, looking at the whole clinical scenario, but under spinal or epidural, if possible. If the baby's heart rate stays down, yes.
Hi, can I say something?
Go for it.
So just on the topic of the GA, just because this happened on my shift, so just to give a bit of a backstory, when this woman's epidural was sighted, it was literally just before the reg was taking another lady for section. So the anaesthetist had done the epidural, they then went to theatre, then the woman's epidural was never effective. So I understand wanting to do the cat 1 under epidural or possibly doing a spinal, but by the time we had got to theatre for her section, she was in such discomfort. Like her epidural was never, maybe it was effective for all of 5 minutes. And then for an hour and whatever the reg was in theatre with the other lady, it wasn't effective. So then obviously then when we're in theatre and it's still down, it's like we actually haven't got time to even try, because then that would mean possibly reciting all of it. And where, you know, she's big BMI, she's all over the place, she wasn't keeping still. I think that was the reason why it was like, okay, the GA is the best option at this point. Also, as well, just to note, because you said you would have moved to theatre, the reg literally came out of theatre with the other lady as the emergency bell was being pulled for this one at 6:15 or whatever time that was.
Yeah, it's not, Erica, is not about a specific case. You know, like we are not talking a specific one. So the common rule that even was exacerbated and augmented during the COVID time, when we really didn't want to GA anyone because of the COVID, is to avoid GA as much as possible.
Yeah.
Our colleague anesthetists are very good in putting a quick spinal. And when we say to them, listen, I want this baby out, all what we need is to convey our message. And I know for sure, having, you know, like seen our colleague staff grades and senior doctors in the night, quick spinal, and and we proceed.
Yeah.
And GA from spinal will be an extra maybe 2 minutes. So
Yeah.
what I want to say is that we need to involve the anesthetist rather than putting pressure on them. I know what you say, Erica. I know at this point the panic, the adrenaline, everything. But if we would have been one step ahead and given terbutaline in the room, and the base, you know, like the heart rate recovered to 140, 150, 160, even with some tachycardia, I would be more inclined to be under spinal than under epidural or whatever, rather than under GA because of the risks of GA. I'm still insisting, yes, if it is not recovering, yes, we need to convey the message. I'm sorry, I would have loved to wait, but we would love a GA. But also in combination, because you might have what we are not factoring in this session or in our obstetric side is the competency level of the anesthetist. And I'm not saying they are incompetent. They are very, very, very competent. They are very good. The second point is the airway of the woman. When it is classified as a difficult airway, it is going to cause us a problem. And it is going to cause us that the woman herself might die. And then we lose woman and the baby.
Yeah. Makes sense. No, I get it.
Okay. So based on this case, what we'll do our classic guess the gases. Erica, you probably know them, so
I won't spoil it for anyone. I'll let people guess. I won't say anything.
anybody want to have a guess at gases and APGARs?
710 and upguard of upguard of 899.
That is very optimistic, Mr. Dagib.
Anybody else want to comment? If anybody's writing a comment, I can't see it, so someone's gonna have to read it out.
Sorry, I'm still kind of calculating. So if you did indeed have an acute hypoxia from 6:15, if I round it up a bit, to time of delivery is just 1:45, that's 1 hour. Acute hypoxia, the pH falls 0.01 every minute. Then you quite actually have fallen by 0.3. So even with the kind of normal pH to start with, which I think this baby had, but it buffered because it used chemo declaration. That means that you're talking about a arterial pH of less than 7. So therefore, you're then in the 6.9 area, and -1 then would be about 7.05. And that then also means with meconium that you will have a baby that requires substantial amount of resuscitation. Fact is that it's so long that you might not have a good outcome at all. This baby is not asphyxiated. Does that?
Thank you. Did somebody say APGAR? Sorry, I don't know if it's my sound that's going really bizarre. If anybody else is hearing that, can somebody say that again? the
Yeah,
last comment.
we are hearing it. Another mic is on, so that's why.
Oh, okay. Anybody else want to have a guess? Petronella, Shivs?
Arterial 7.01, Venus 7.1, Apgar's 689.
Shivs? I'm calling on you because you're the only ones
Sorry,
I've heard
I'm
speak.
in a house. 1 sec. Let me run away. Oh, I don't know, guys. I don't know. I feel like I'm going to be surprised.
Absolutely.
Be normal, aren't they? I bet they come out normal.
Quite the opposite.
Surprise us, Cara.
I will put you out of your misery. Unfortunately, we could only, well, I'll let you guys decide that. This baby was born with APGARs of 1, 4, and 4, required extensive neonatal resuscitation and was intubated at 8 minutes of life. Arterial pH was 6.75, base excess was undetectable, lactate was 14.9, and then venous pH of 6.76, base excess again undetectable, and lactate of 15.
Well, I think with how it looked, but I think because of obviously it was like, what do you think the gases are? I think it seemed like maybe this would be the one that had the normal gases, but clearly not.
I know. Normally I do these cases, and we all think that they're going to be a lot worse than they actually are, because these babies are incredible at compensating. But yeah, this unfortunately was a case that wasn't so good. Erica, correct me if I'm wrong, but am I right in saying that this was actually a concealed abruption?
It was a concealed abruption. I think there was a massive clot behind her placenta, and I think it weighed about 1.5, 1.6, not excluding the other EBR that she lost. So yeah, concealed abruption as well.
Anyone see that one coming?
No, we were just wondering if she was acting a lot more than she was, and when she was given the terbutaline, that probably then kind of kick-started it off, no? Because it's maternal bleed with an abruption, isn't it? And then placenta is being shared off, and that is an effect of terbutaline. So the question that I had was earlier when they did the VE, what did they think they were finding? But you didn't mention any blood. But I mean, do you the rule of 3 and Freud?
The 36912 rule.
Yeah.
Yeah, we do.
Right. So because you could actually try to determine in the first instance what's the cause, no? If you think that you have an abruption called uterine rupture, then you quite literally are in theatre like ASAP. You wouldn't give terbutaline. If you think most common cause this is a kind of hyperstimulation, you would. But it always depends on what it is. That also then depends upon your speed. But I didn't see that coming. I just was wondering about why is there such a kind of the CTG didn't look hypoxic enough for me to bail out, but it all started off after the terbutaline, no? So therefore, that then would, in hindsight, I didn't see that earlier, only in hindsight, essentially explain the potential scenario.
Yeah, so now that we know what we know, just going back, registrar obviously comes to assess at 0445, and terbutaline given at 0500. Do we think that this CTG trace is worse than the previous?
No, and to assume that most cases will be abruption will be a big mistake not to give terbutaline. So I again, yes, it is possibly that the findings in the cesarean is abruption, but yeah, it doesn't put me off using terbutaline, unless in one scenario there is overt bleeding in front of me, there is like antepartum hemorrhage, I wouldn't give. That's the only contraindication. Otherwise, no.
Yeah, and also just to sort of point out, this midwife was reporting contractions and no external sort of symptoms of abruption were ongoing, other than maternal distress after the epidural. As Erica said afterwards, that her epidural wasn't working particularly well.
Out of interest, is this the one that happened 6 months ago or so?
No.
Sunday night.
Okay.
Sorry for everybody who was involved, because that's obviously very traumatic. I hope that your staff is well, and I'm just wondering how mom and baby are doing now, because it looks as if HIE1 only. Is the baby okay?
Yep, so baby's made a really, really good recovery. Is still in our neonatal unit at the moment, but hasn't required any cooling and is doing well. And mum, I believe, is doing well too, and is on our postnatal, is now happy on postnatal ward.
Delighted to hear that. Thank you.
Perfect. Does anybody have any questions or anything else that they want to add?
May I say something, Tara?
Please, Maya, do.
I'm obviously, like, from, you've followed me through CTGs, and I'm someone who's incredibly cautious with terbutaline and abruption. And now this CTG now puts me in a very critical situation, because obviously now I'm trying to get more brave with kind of like occult APH and feeling easy with terbutaline. And now this case actually puts me steps back. Because, to be fairly honest, now it gets me back to square one, where I have to be incredibly cautious with terbutaline and CTG. So I don't know, Mr. Naguib, can you help me here?
Oh, yes, Maya. You know, again, I am, as maybe most of the people know, and as I am one of the children of the School of Georges, where we have terbutaline on the wall, really. Again, I would say, unless the bleeding is overt in front of you with antepartum hemorrhage, and truly an abruption in front of you, you should be given terbutaline. You don't know, of course, we should believe the findings, but you don't know the 1.6 behind the placenta was present before the terbutaline. I am not really, if it is a blood clot, I am not going to try to believe even that the terbutaline has made 1.5 liters loss inside the uterus without manifesting itself, without showing any signs of compromise of the mother, without this mother collapsing, without this mother feeling so much pain, with epidural that is mentioned, that the epidural that has not worked and gone to GA, meaning that the epidural was not very effective. So she wasn't expressing so much pain. I can't believe that terbutaline has made so much impact that this is the case. In many situations, and I have witnessed it, and again, I'm not at one point saying that the findings of the cesarean are different, but in many times the clots that we find inside the uterus and behind the placenta and we describe are operator made. I have made some. I'm opening, I'm going through the placenta because the placenta is anterior low, which was mentioned that it is anterior high, and I remove clots. So the lady is bleeding, and I remove clots. So the head is -2, -3. Why all this bleeding is not coming through? This is maybe an organized something from before. So I would be saying that terbutaline is one of the best drugs that help, and the only contraindication that I see the blood coming outside. That's it. So don't be put off, please, Maya. You will save hundreds and hundreds of babies, and don't be put off for one case. In this case here, we were saying from earlier that, that I mentioned a few times the toko. The toko was so weird. But at the same time, if the toko is so weird and we are not like seeing what is happening, and the examination is -2, and the decelerations and so on, yes, we said, and I wouldn't go back and say in retrospect I would have sectioned, no. But at the same time, I would love to relax the uterus and see what's happening. And when I examine again and there is no progress, possibly for failure to progress because the picture doesn't add, the what Dagmar mentioned about the cephalopelvic disproportion, the whole examination. So, but this doesn't put you off having terbutaline. Definitely not.
I feel I have to apologize to Maya because it might have been my comment stating maybe it was triggered off by the terbutaline. The timeline, though, doesn't really fit Maya. The terbutaline was given at 5:04, if I got that right in my timeline.
Yeah.
And the kind of actual final detrimental abruption occurred an hour, almost, more than an hour later. That would be a very well concealed abruption if you had indeed 1.6 liters accumulating in that period of time until the placenta finally peels off and then quite literally kind of goes. Never say never in medicine, and I think it's kind of good to be cautious about anything that we give and the effects that we can have with that. But I also agree with Naguib, or Mr. Naguib, that it is not likely, and I apologize if my comments that came a bit from hip level essentially caused anxiety now about this. So sorry.
I think it's really good that we have, obviously everybody in medicine's got very, very differing opinions on, I mean, somebody might classify a trace as slightly more suspicious and somebody might classify it as pathological, but actually having a conversation as a team and also different types of clinicians is really, really important to try and analyze this and see moving forward if we would do something differently next time, if we were to look at the exact same thing. But also we've all got different experiences of what different medications can do, how CTGs are interpreted. I mean, nobody really expected these gases to be as poor as they were, considering what the trace was like beforehand. So I think it's really good to have these. This is why I love doing these sessions, so that we can all learn from them and maybe change certain things in our practice and maybe keep to the same practices in other ways as well. So thank you everybody for contributing. It's been a really interesting case, this one. And yeah, I definitely didn't see this coming when I found this earlier on today, and I knew I wanted to present this one this evening because it's a bit of an eye-opener. But yeah, does anybody have any further questions?
No, thank you.
Absolutely fantastic. Yeah, thank you.
Thank you, everyone.
I just want one last thing to say, and this is to anybody who does risk analysis from obstetrician colleagues and or from senior midwives and so on, is such cases, similar to any case, should be seen as we did today, in prospect, not in retrospect. In retrospect, all of us are so smart. So I think if I'm analyzing this case in prospect, I would have said I would not agree with the CENTO, as we said. I would say not for section still, and so on. So I mean, we shouldn't be criticizing ourselves in retrospect, only in prospect.
Absolutely. Perfect. Thank you, everyone.
Thank you so much, Cara. That lovely case. Thank you so much.
Thank you.
Bye.
Bye.